Hey everyone, this is Dr. Madden's group, and we're going to present our case study on our patient named Holly. Holly is a 34-year-old bank manager. She's married, and she's a mother to an 8-year-old child. She was referred for an evaluation by her son's pediatrician due to being overcome by the stress of her son's illness. She describes feeling very worried after her son was diagnosed with asthma within the past year and hasn't been able to sleep for the past 5 or 6 months. Her son recently suffered an acute asthma attack at school, and she becomes tremulous and tearful while talking about it. She admits to feeling more tired and demotivated. She enjoys her job but found it hard to concentrate and worries that she might make a serious mistake. There are days where she found it difficult to get out of bed. Her affect is anxious, and she describes her mood as low. She's cooperative with good eye contact, and her speech is normal. She's healthy and has no past psychiatric diagnoses or admissions. There's no overt psychotic symptoms. She completely dismisses any idea of self-harm or suicide and states she would never think about it. She presents with cold, sweaty palms and states her heart is beating fast. A couple screening exams were performed during Holly's assessment. Her GAD-7 showed a score of 13. Her PHQ-9 showed a score of 17, and the DIG-FAST questionnaire for a bipolar disorder was negative. All of her labs were within normal limits, and there was no concern for any underlying medical condition. Some of the differential diagnoses that our group had discussed was adjustment disorder, based on the fact that her son's asthma attack appeared to be a catalyst for the onset of her symptoms. We did consider major depressive disorder due to her low energy, her low mood, as well as her difficulty to get out of bed. As well as we discussed generalized anxiety disorder, seeing as anxiety was the largest symptom that she had expressed. Overall, we came up with a diagnosis of major depressive disorder with moderate anxious distress. She met at least 5 of the diagnostic symptoms within the DSM-5. Her PHQ-9 of 17 equaled a moderate or severe depression. The symptoms deviate from her normal baseline. She was experiencing poor sleep, a lack of motivation. She feels fatigued. She feels guilty for being emotional, and she has a low mood. Her GAD-7 was 13, which equals moderate anxiety, and she did experience 3 or more symptoms that include moderate anxious distress. Her symptoms were inability to concentrate at work, believing she would make a mistake, and tense and anxious during the interview. Upon conversation, our group decided to go with an SSRI to start. Citalopram 20 milligrams by mouth daily was the lowest recommended dose for this specific medication. It is first line for anxiety and depression, as well as it may be more tolerable than other SSRIs. We did provide some educational pieces for the patient so that she is able to be educated on the medication that she is starting on. She doesn't have a history of psychiatric diagnoses, so it is important to include these things. We would like to note that full effects of the medication can go 4 to 6 weeks without being felt, but then we would educate her that if she doesn't feel that she has met an optimal for follow-up, that we will increase the dose. Common side effects that she may experience are nausea, headache, dizziness, decreased appetite, constipation, or a dry mouth. Our group is also suggesting that we start her on trazodone 25 milligrams by mouth nightly scheduled. Trazodone at low doses can be used to improve sleep. Side effects we would like to educate her on is nausea, vomiting, blurred vision, constipation, dry mouth, and dizziness. Some non-pharmacological recommendations that we have for this patient is to begin cognitive therapy. This is an individual therapy that will help the patient identify and cope with the distressing factors that she is experiencing, including dealing with the information of her son's illness. We also suggest a family therapy. This will allow the patient and her family to reduce the stress and learn coping skills and maintain therapeutic relationships among each other. It was noted that the patient and her husband had stopped trying to conceive when these symptoms started to present themselves. Therefore, a family therapy would be beneficial for this family. For a follow-up plan, we will schedule the patient 4 weeks out to monitor a response to the medication. We'll also provide the patient education on the medication and the non-pharmacological treatment recommendations. We'll give the patient instructions to call the office immediately if she experiences any medication adverse effects, worsening conditions, or any thoughts of wanting to harm herself or others. Once she does follow up, we will discuss the medication effectiveness as well as increase the dose of the trazodone and citalopram to therapeutic levels and reschedule a visit for 2 more weeks out. If the medication is effective, we will change trazodone to as needed for sleep rather than scheduled. We feel Holly has a strong prognosis due to her ability to make her needs known. She has a supportive family. She has decent housing with a stable job. She enjoys what she does. She has no previous psych diagnoses, no substance use, and she is rather healthy. She is challenged by inadequate coping skills and limited insight, but her influential factors are her husband, she's motivated to feel better, and she has hope that it will get better. Throughout the process of this case study, our group all came to the same consensus that the diagnosis we had was an appropriate one using the DSM-5. We did experience many opinions based on the treatment recommendations. Everybody has a different experience, observation, and perception of the case study, and one of the main topics of that conversation was whether or not to start a benzodiazepine for the experienced anxiety. Overall, we decided to take a lower route to begin treatment based on patient presentation, with the thought that if it did escalate, a benzodiazepine was always a good step. And here are the references that we used for our case study.